starting off on the right foot. So many of you will ask, how do I even start the presentation? So as you know, for the exam, there are 18 stations, 2 rest stations, and 16 stations that you'll actually have to perform in. And you'll have a minute and a half to do the reading, and then 8 minutes in the actual station, and you will have a buzzer at around the 2-minute point. So how do you get started? You need an introduction that is as concise and as short as possible and gets the job done, because we don't want to be faffing about and wasting time on the introduction. Oh, is it okay if I call you this? Would you prefer if I call you this? Can you confirm your date of birth and address? This is all a waste of time. You are cutting into your actual station time. So all you need to do is you need to keep it professional. If you keep things professional, you could never go wrong and no one can mark you down on it. So you always say, hi, or good evening, or good afternoon, or good morning, whichever. Hello, I'm Dr. Maksud. You use your surname, not first names. Are you Mr. So-and-so? Are you Mrs. So-and-so? If you're unsure as to the marital status of the female, then are you Ms. MS? Are you Ms. So-and-so and the surname? We only go off surnames. We do not use first names. So, hello, I'm Dr. Maksud. You don't have to say I'm one of the doctors in the department, because if you say in the department, okay, well, you might be in a GP setting, you're not even in the hospital, so there isn't a department. So don't put yourself in an awkward position. Just say, hello, I'm Dr. Maksud. Are you Mr. Smith? Okay, great. How can I help? And that is it. And that is how you get off on the right foot. Okay, there are some stations that have exceptions where you need to confirm things and details. For example, the telephone stations. That is going to be covered more in our PLAB 2 course. Again, as I said, we're going to be rolling out advertisements and dates for things and all the details in the coming days on the WhatsApp groups. So please keep an eye out for that. So this slide is the key to passing this exam, okay? Because the consult is a tale of two halves. What do I mean by that? You have the beginning and you have the end. This is the key to passing, guys. You need to have this structure in your head. This is the structure that you can apply to any clinical scenario. A lot of people in the past, they've been told that they need to memorize the stations. The stations now, 300, 400 plus stations. And the stations that are known, they can tweak them and the whole station changes. That is not a practical approach, guys. We need to have a structure that we can fall back on. If you hit these individual points in the scenario that you are presented with, you will get the marks and you will pass. And this is a structure that you can even use to pass your Royal College exams in the future as well, if you've not specialized already. So let's get into it. So the first half is, first of all, you're reading the station outside. You need to sort of gauge what possible issues there might be, okay? Is there a domestic violence station? Is it that we've gotten a diagnosis wrong or have missed a finding on a scan? Okay, you need to gauge what sort of confrontation there's going to be. So first of all, the first thing you need to do are 3 things in the first half. Okay, so what I start off with, I say is, hello, I'm Dr. Maksud. Is that Mr. Smith? Yes, it is. Okay, great. How can I help? I give that person a minute. Now you're going to say, God, I'm going to give them a minute out of the 8 minutes. You're really going to have to hold your nerves and give them that minute. That's called the golden minute, because the patient is going to tell you everything. The actor is going to tell you everything. Okay. Now, in that 1 minute, as you're listening, and you really have to calm yourselves down and actively listen in that 1 minute, because the patient is going to tell you the station. They're going to tell you the points that you need to hit. So once you've given them that 1 minute to just vent, you will be repaid at the end. You'll have plenty of time to actually do your data gathering, to do your management, and to display your interpersonal skills. So now we've got that 1 minute over and done with. At that point then, you want to talk about red flags. Okay, Mr. Smith, so you've mentioned weight loss. Did you lose that intentionally or unintentionally? And how much weight did you lose, and in how much time? Have you noticed that you sweat at night? Do you have any itching? Have you got any lumps or bumps on your body? And you need to pick, I'd say, about 3 red flags maximum. We're not doing the whole Kumar Davidson textbook of medicine, okay? 3 to 4 red flags maximum. Then at this point, you need to decide what extra history is relevant to the station, okay? So for example, if someone has a rash in the groin, then sexual history would be relevant here. But you need to signpost, okay? We'll talk about signposting in a second, okay? But what I'm saying is that you need to decide what extra history needs to be asked, whether it's a sexual history, whether it's a drug history, whether it's a past medical history. So Mr. Smith, what other medical problems do you have? So apart from the issue of coming today, Mr. Smith, what other issues do you have? Or you might say, so Mr. Smith, I'm going to ask you a bit of a personal question, and that is just to understand what's going on here and to give you the best treatment. Is that okay? Yes. All right. So Mr. Smith, can you tell me, are you in a relationship at the minute? Okay, so that is social history. All right. Also drug history. Okay, so Mr. Smith, I think I know what could be going on here. Could you just let me know if you're on any regular medications? So again, just to recap, you're going to introduce, you're going to give them the golden minute, you're going to let them speak and vent to you, and then you're going to hit 3 or 4 red flags. You're going to ask any of the history that you want to do to whittle down the diagnosis. And remember, what the examiner wants to see is you're considering differentials. So for example, for headache, you need to rule out subarachnoid, GCA, and stroke as sort of the top 3 diagnoses that you don't want to miss. After that, then we can talk about tension, headache, migraine, the less dangerous differentials. But you don't have to cover all the different hypothetical diagnoses for headache, but what the examiner wants to see is that you're considering other diagnoses, okay? So just because you see an old lady who's come in with scalp tenderness and jaw claudication, and she's brushing her hair and it's really, really sore, that's obviously GCA, but we just want to think, okay, so you said the headache is here, so it's not at the back of your head. Just to make the examiner feel, okay, look, I'm asking her, is it an occipital headache? Is it thunderclap? I've considered subarachnoid, but it's quite obvious that ultimately this is probably GCA or superficial temporal arteritis, okay? So that is the first bit. Red flags, a few questions to consider other differentials, and only relevant additional history, whether it's a past medical history, or whether it's a social history, or whether it's a sexual history, whether it's a family history. So if someone has come in with, familial adenomatous polyposis, and you say, does anyone in your family, don't say, do you have a family history of? That's considered jargon, okay? What you want to do in this exam is you want to avoid medical jargon. You have to speak in layman's terms. And in the full communications course, we will have all the layman terms there for you, so alternatives. But for right now, you don't want to say, do you have a family history of? You want to say, does anyone in your family have? Does anyone in your family have X, Y, Z? Okay, so that's the first bit. And then we move on to psychosocial. So why do I ask psychosocial? Because this helps to build up rapport with the patient. And what I remember is the mnemonic WASH, W-A-S-H. If you remember W-A-S-H, then you've covered your psychosocial, which means what? Work, alcohol, smoking, home. So I say to them, Mr. Smith, just because this is the first time us speaking to each other, I was just wondering, can you tell me a bit more about yourself? What do you do for work? So I've covered work. Remember, it's not always relevant, but so alcohol and smoking might not always be relevant to that station, but work and home is nice just to ask. Okay, so Mr. Smith, it sounds like you've been having a really tough time with these symptoms. Who's your support network? Who do you live with? So now I've asked about home. Okay. So who's at home with you, Mr. Smith? We know, what's your support network? Who do you go to if you have a problem? Okay. So, Mr. Smith, I'm sorry if this is a bit intrusive, but might I ask, how do you sort of survive financially, or how do you deal with things financially? Is there anyone supporting you at home? Okay. So, Mr. Smith, I was just wondering, are you sort of able to carry out your daily activities, such as, for example, washing and feeding and getting your clothes on in the morning and things like that? Are you managing okay? That's psychosocial. So, Mr. Smith, I'm just going to ask you a few questions regarding your lifestyle. These are questions that I'd ask any patient. It's just it might be relevant to what's going on here. I hope that's okay. Do you happen to drink at all? So I'm asking about alcohol, but see how I signposted that. Again, we'll talk about signposting in detail in just a second. You can't just ask him, Mr. Smith, do you drink alcohol? Because it seems abruptive. It seems that it's just come out of nowhere, out the blue. And what you want to do is you want to have a flow and a rhythm to your consult. You want it to be structured. Okay. I mean, I think, when I was examining people, if I feel there is structured, they might wobble a bit in the management, but if I feel there is structured, I do give them the marks. So you don't want to be abrupt. You want to lead into it. I'll talk about signposting and what that means in just a minute. For smoking, again, I say, okay, and off the back of us speaking about drinking, have you smoked at all? Now, if someone says, no, I don't smoke, you say to them, okay, so have you ever smoked? Because they might have stopped smoking right now. They might have just quit yesterday, and now they're telling you, no, they don't smoke. But you say to them, okay, so Mr. Smith, so have you ever smoked? Oh, I smoked when I was in my 20s. Okay, but so there is technically a history of smoking there. So you need to show the examiner, no, I managed to get it out, that there is smoking. So anything else that might be relevant, so drugs, for example. Again, Mr. Smith, these are just routine questions that I'd ask any patient that comes in with your symptoms, and it just helps me gauge what's going on here, and that way I can give you the best outcome. Okay, Mr. Smith? All right. So as I said, this is just a safety question. Are there any recreational drugs involved here? Oh, no, doctor, I would never touch drugs. Okay. So let's just recap what I've said. The consult is in two halves. You want the most concise introduction that gets to the bullseye, that gets to the point. Hello, I'm Dr. Maksud. Are you Mr. Smith? Okay, great. How can I help? The exceptional stations we'll talk about in the PLAB 2 course. Then you go on to give them that golden minute. How can I help, Mr. Smith? Let them talk. Let them talk. You will be repaid at the end of the station. Okay. Now, if you want to butt in, you can say, oh, Mr. Smith, it sounds like you've been having a really bad time with this. So you mentioned weight loss to me. Have you got, and then you can go into your red flags. Okay. After the red flags, decide what other hypothetical diagnoses you want to exclude. So what differentials you want to exclude, then decide what additional history you want to ask about. If you don't know why you're asking something, then don't ask it. So for example, I don't know why I'm asking this guy about itching. Don't ask it. Oh, I'm asking this guy about itching because it might be a B symptom for lymphoma. Then ask it. Okay? So don't ask things that you don't know what the reason behind it is, because you'll be wasting time. And then you move on to psychosocial, remember WASH. So just because it's the first time us talking, Mrs. Smith, can you let me know about yourself a bit more? So what sort of thing do you do for work? Oh, I'm retired. Okay. Right. And how long have you been retired? Okay. And what were you doing before that, Mrs. Smith? WASH. Work, alcohol, smoking, and home. So who's your support network? Who's at home? And then we move on to ICE. Okay. Now, why do we have to do ICE? Because that will give you the whole motivation behind this scenario. Okay. So for example, so how would you do ideas? So this is what I do, because if you say to someone, do you have an idea about what's going on here? They'll be like, well, I don't know, you're the doctor, why have I come to you? Okay. So a better way of saying it would be, so Mr. Smith, I think I know what might be going on here, but just out of interest, I was wondering, do you have any ideas about what's going on here? So I know, and I've got a plan, but I wanted to know your opinion as well. And that again involves the patient. It brings them in and it builds that rapport. It's a conversation between two people. That's how you want it to come across to the examiner. Okay. So again, so Mr. Smith, I think I've got a clue here. I've got an inkling about what might be going on, but I was just wondering whether you had any ideas. Oh, well, doctor, I Googled that it could be lung cancer. So now they've given you something that they're worried about. They've given you a concern, and that leads very nicely into concerns. Oh, I see. Okay, so that must have been very distressing for you thinking there is cancer. Was there anything else that you were thinking or worried about? So was there anything else you were worried it could be? So he told you about lung cancer. Oh, well, my wife was worried that it could mean that my prostate is very enlarged. So it's a conversation. Now, in ICE, you want to state your reasoning, okay? In concerns, you want to state, okay, so you think that it could be cancer, okay? Well, is there anything else that you're worried about? And then in expectations, then you say, okay, so Mr. Smith, I heard at the very start of the consult that you were saying that you think you might need antibiotics. Now, that may very well be the case, that you might need antibiotics, but there may be another treatment that we could offer you. So is that all you were expecting for today? So remember, that demonstrates active listening, because they said at the beginning of the consult, oh, doctor, I've been having this cough now for 2 weeks. I feel like I just need antibiotics, because the last time I took antibiotics, the cough went away. So you say to them, okay, I hear you, Mr. Smith, and I'll definitely get back to that in a minute, I promise. If the actor or the role player starts to segue on tangents and starts to lead you down a rabbit hole, all you have to say to them is, oh, Mr. Smith, yes, that's very important about you going to work and attending work regularly. That's a very important point. I'll get to that in a minute, I promise. And then come back to what you were asking. So you were saying that you were losing weight. Can you tell me how much and what time? So any meandering, any going off the point, you just say to them, you acknowledge the point that you've brought up, Mr. Smith. It's very important. I'll get back to that in a minute, I promise. And then come back to the point that you want to say. You have to show the examiner that you are in control. You are in the driving seat, okay? Because somebody has to, otherwise the whole station is going to go from you, okay? So again, to recap. 1, you're reading outside, you're trying to gauge what the issues could be. You come in, you do your concise introduction. You give them that golden minute. You start with your red flags. You work on differential diagnoses. You decide what other relevant history you can ask about. Then you move on to psychosocial. You do your wash. Alcohol and smoking is not always relevant. And then you go into ICE. So you have an idea about what's going on, but I was wondering whether you had any other ideas. I heard that you were worried about cancer. Is there anything else that you're worried about? Or maybe they don't say what they're worried about. So you say to them, it sounds like these symptoms are quite distressing to you. They've been disturbing your life recently, really. It certainly sounds like these symptoms have been occupying your mind. Is there anything that worries you about all this? Or, oh, so Mr. Smith, what I'm hearing is that you think that potentially you might need antibiotics, and that might be appropriate, but I was just wondering whether there's anything else you were hoping for from today's consult. Okay. Then we can move on to doing our examination if the scenario calls for an examination. Okay. And then we go into the second half. Okay. And in the second half, this is your management. Now, you need to leave enough time for management, guys. People fail because of the management. That's why I want you to stick to the points that I've mentioned so you can get through the data gathering bit as quickly and as smoothly and as professional sounding as possible. You hit the checkpoints that I've mentioned, and then you have to move on, okay? If, however, in the management, you've forgotten something essential in the data gathering, you can say, sorry, Mr. Smith, I was supposed to ask you about this earlier. I'm sorry about that, but have you got any bleeding from the back passage? So just say, sorry, I meant to ask earlier, X, Y, Z. Sorry, I meant to ask earlier, X, Y, Z. And you can recover that way. And it's sort of a smooth little segue, and it doesn't sound like it's come out of nowhere. Sorry, Mr. Smith, I meant to ask you earlier about X, Y, Z. Okay. So in the management, how do we start? First of all, you say, so if it's a sort of a normal diagnosis, not something that would be shocking to the patient, and we've got the Breaking Bad News station coming up, you can just simply say, okay, Mrs. Smith, so I actually think what might be going on here is that you have an underactive thyroid, which is what we call hypothyroidism. Do you know what this is? You must verbalize a diagnosis. If you cannot, so there's something in the pitch of our voices called intonation, okay? So the way I said that then, if you notice, I said, it sounds like you might have an underactive thyroid, which is what we call hypothyroidism. Do you know what that is? I raise my voice, because if I say, do you know what that is? It's patronizing. It seems like I know, she doesn't know. The other way you can ask is, if you can't play with the pitch in your voice and you're very nervous, you can say, do you know anyone who has hypothyroidism or an underactive thyroid? So she says, yeah, I know, my sister has that. I know all about that. Then you don't need to do the second step, which is offer an explanation of the diagnosis. So if you say to them, so Mrs. Smith, I think I know what's going on here. It sounds like you might have an underactive thyroid, which is what we call hypothyroidism. Do you know anyone who has hypothyroidism or an underactive thyroid? And she might say, oh yeah, my sister has that. Yeah, I know all about that, doctor. Oh, it's terrible, makes you gain. That's why I'm not losing any weight, isn't it? You say, yeah, I think it might be. And then you can move on with the management. But if she says, oh gosh, what on earth is that? I've never heard of that. Is that dangerous? Then you can offer an explanation. You can start with, no, it's not dangerous, and it's a very manageable condition, but it's essentially we're replacing the hormones in your body that your body is not making. If you want me to go into the details of the hypothyroid station, it'll be in the PLAB 2 course. I'm wary of the time that we have now, but there's a whole way of managing that particular station. So you give the diagnosis. You must verbalize a diagnosis, and then you offer an explanation. We're not going to go into explanations. We're going to offer an explanation. We're going to ask them, would you like me to explain what that is, Mr. Smith? Because if they don't want to, then fine, we can move on, okay? Then we are going to actually do the management, okay? Now, sometimes in management, there'll be multiple points to cover, okay? And we want to ensure that the examiner knows that if we had enough time, we would have covered these individual points. So we must put all our issues out there in front of the examiner, okay? That's if there are multiple points to cover. If there aren't, then we can, slow down a bit, and I'll show you both approaches. So say there are multiple issues to get through. So say, for example, someone has hypertension, they have high blood pressure, okay? You're going to have to cover the medication that you're going to start them on. You're going to have to cover potential side effects of the medication. You're going to have to cover lifestyle modification, so diet and exercise. If they're smoking, they have to stop smoking, etc. You're going to have to cover safety net, in that if they develop severe headache or chest pain, that they need to call 999. And you need to give them follow-up. You need to tell them that after we started you on this medication for 4 weeks, we'll ask you to measure your blood pressure again for 4 to 7 days at home, and then we'll average those readings, and then we'll tell you whether you're on the right dose or whether we need to change the dose. So there's 5 things here. Can you do that in an 8-minute station? No. But you need to let the examiner know that if I had time, I would have spoken about these things. So Mr. Smith, now that we've established that you potentially have this high blood pressure, there are a few things really that are quite important that we cover. Now, don't keep talking in the management station. If you're talking for more than a minute, you're going to be losing IPS, interpersonal skills marks. So what you need to do is, you need to do check and check. So I'm just going to change the slide here, because now we're going to go on to the techniques, okay? So when you're doing the management, what you're going to say is, for example, so Mr. Smith, I think we've established now that potentially you might have high blood pressure. So there are a few things that I feel are important that we should discuss and you should be aware of. Is that okay? And then give him a second, say, yes, it's okay. All right. So I think it's important that we discuss medication, okay, and how we would monitor that. Also, I think it's important that we discuss the other tests that we need to complete your workup for high blood pressure. I also think we should take this opportunity to perhaps discuss things that we can improve in your lifestyle to help bring your blood pressure down a bit. Also, I just need to give you some safety information. So, Mr. Smith, if I'm going too fast, please let me know, and I'm happy to repeat everything I've just said. Oh no, you're okay. Just keep going. Okay. And then finally, I just need to give you some advice on when to call 999. So, which would you like me to start off with? You need to do pauses, and you need to do what's called chuck and check. You chuck some information to the patient, and then you allow them to respond, because that shows that you're not hogging the consult. You're not just constantly speaking because you haven't got time and you need to rush through the management. And at the same time, I've now shown the examiner that I've got, if I had time, I would have gone through all of these, Mr. Examiner, so don't mark me down. And also it just sounds so nice. You know, if someone's recording it and you hear it back, it just sounds professional, it sounds organized, and also you've covered all the points, even without really covering them. So chuck and check. So Mr. Smith, we're going to go through the blood pressure medication. Okay, is that all right? Yeah. And then he'll say, yeah. Just that little intermission of a yeah or a yeah, I'm with you. Okay, are you with me, Mr. Smith? Okay, am I going too fast? Does that make sense, Mr. Smith? Sorry, I think I've talked too much. I'm going to give you a chance to talk now. Is that okay? All right, okay. Does it all make sense? Do you have any concerns at this point? Chuck and check. With open and closed questions, that's more relevant to the data gathering part. So open is basically, how can I help? That's a very open question, and you've got that golden minute. Closed questions are we're zeroing in. How much weight have you lost and in what time? So you want to start with open, and then you want to go with closed. So open are broad questions. You're giving the stage to the patient to tell you everything that they're worried about. Closed question is me zeroing in when I'm trying to get that differential diagnosis, when I'm trying to ask those really specific points. Okay, so Mr. Smith, just a few lifestyle questions. These are questions I would ask any patient that come in with your symptoms. So, do you smoke? Okay. Patient-centered. Now, patient-centered, it's really an art, okay? You can't make it about you. I think we need to. I want you to. It's really important that I. No, you must say we. So, Mr. Smith, I think perhaps we should consider different lifestyle changes that we could implement, and this could help to bring down your blood pressure. What do you think? Patient-centered. So, Mr. Smith, I heard you at the beginning. I heard you, okay? I heard you at the beginning that you were wanting antibiotics. Now, when I was asking you initially at the beginning of the consult, I felt that maybe that was going to be what I was going to give you today. But actually, what it sounds like, and after listening to your chest, is that you actually have a virus. Do you happen to know what the difference is between a viral and a bacterial infection? It's about him. So I acknowledge that you did want antibiotics, but then when I heard your chest, something told me that something else is going on. You're giving your reasoning, but it's about the patient. So, Mr. Smith, when somebody has reflux or they're experiencing heartburn, there are sort of two ways we can go about treating this. Would you like me to tell you the options? Okay. So the first option is, and this is for people who the symptoms are really bothering them. So the first option is that we can try an antacid tablet for a month. Okay, so that's the first option. Does that make sense? All right. And the second option, Mr. Smith, is that we do a camera test. Or the second option, Mr. Smith, is that we do a stool test. And that stool test would check for a bug in your tummy, because that bug might be the reason why you're producing all this acid. So which one do you feel, would work better for you? Would you like us to get the symptoms under control, or would you like us to test for the tummy bug? Or doctor, why can't we do both? Okay, yes, sorry, I forgot to mention. So, well, we can't do both, because if we give you the tummy tablet, then that means that the stool test will be inaccurate. Does that make sense, Mr. Smith? All right, well, to be honest, it's really bothering me at work, and it's really disturbing me, and I'm having to drink lots of water because I keep getting that acid in the back of my throat. So maybe I'll just go for the tummy tablet. Okay, that's perfectly all right. So I will definitely write you a script for that, and you can get it ready this afternoon from the chemist. Is that okay? Patient-centered. You give them the options so that they can make an educated decision. The next then technique is acknowledge everything. So the whole time I've heard you. I'm seeing that you're distressed. Oh, I realize that you're very worried about work, and that is important, and I'll get back to that in just a minute. Oh, I can see that you're very worried about your wife. Obviously, it's very important that we look after our family. So I'll definitely consider that when when I tell you what we're going to be doing about this. Verbal and non-verbal cues. So non-verbal, if someone is not giving you any eye contact or is very fidgety, say it. Say, I'm getting a sense that you're quite nervous coming to see me today. Am I off, or is that right? Yeah, doctor, I've been very, very nervous, to be honest. I just didn't know where to go, where to turn to, and I'm just very, very worried because, you know, people are after me, doctor, and they're trying to get me. Say, oh gosh, people are after you. Can you tell me a bit more? Yeah, doctor, they're putting cameras in my room. Schizophrenia station. Okay. So if you see something weird, say it. Oh, I can tell that you're very distressed. Or I can see how frustrated you are, Mr. Smith. And if I was in this situation, I'd be just as frustrated as you. And we'll talk more about that in just a second. So in these techniques we've already sort of touched upon. So rapport is really constantly being built up, you know, in all these in all the different parts of the consult constantly. So you need to say, no, just have a bit of empathy. I can see you're very distressed. This must be very frustrating for you. I can't imagine what you've been through. Oh, you've got all these symptoms, because there'll be a multiple problem station. Oh, I can see you've got all these symptoms. How have you survived this whole time? It must have been very difficult for you. Or I hope we can unpack some of these symptoms, and I could certainly try to help you today. In ICE, it says to reflect. So say, you know, what I was doing. So I'm hearing that you're worried it's prostate cancer. Was there anything else that you thought might be going on? So you take you acknowledge and you bounce it back to them. Okay, and I can see your wife was worried about an enlarged prostate. Was there anything else that you or her were worried about? Expectations. Okay, so I heard at the very beginning you were wanting some antibiotics. Was there anything else you were hoping for from this consult, or anything else I could do for you today? Psychosocial, it says relevance. So what do we mean by relevance? I say, so the thing is, say for example, that someone came in with a rash on the groin, and you just say, are you sexually active? They might think, well, I've got a rash. Don't rashes come from allergies? Why are you asking me about my sex life? Okay, so say to them, Mr. Smith, I'm going to ask you a few questions. They are a bit personal, and I only ask them because sometimes rashes, they're not necessarily an allergy. So I just want to understand what's going on here so that I'm giving you the right treatment. I hope that's okay. Oh yeah, doctor, of course, go ahead. Okay, so are you in a relationship at the minute, Mr. Smith? Okay, or you can say, are you sexually active, Mr. Smith? Okay. And then body language. So sometimes mirroring someone's body language might be helpful. Just to, because when you mirror someone's body language, it almost gives that person a signal that you're in sync with them and that you're perhaps understanding of their situation as well. Okay.